I'm worried. Medicare has this digital strategy, and they've proposed to discontinue MIPS CQMs for the APM Performance Pathway, that is the APP. It seems like the writing is on the wall, and one of these days eCQMs will be our only choice. How are we going to make that transition? It seems insurmountable.
Great question, Glenn. Now, I still prefer MIPS CQMs to eCQMs, but whatever direction CMS takes, we can help you deal with it. We can do it together. Now, the primary goal with any quality reporting program is to report your clinical quality performance accurately and efficiently. It has to meet, no matter what method you use, it has to meet that standard that you and I attest to every year. It's complete and accurate to the best of our ability. It can be done with MIPS CQMs, eCQMs, Medicare CQMs, or anything else that Medicare might dream of. Now, Medicare CQMs, we expect to be temporary. Medicare wants us on all patient, all payer reporting, and that's just not Medicare CQMs. Eventually, they will end this in favor of one or more all patient, all payer methods. Now, when it comes to MIPS CQMs and eCQMs, Medicare also wants to get us to all electronic reporting. Many people don't realize that that could mean either, but it can be either MIPS CQMs or eCQMs. Now, eCQMs can't be anything else but all electronic. Nothing else passes as an eCQM. So most people consider eCQMs as synonymous with digital reporting, but you can do MIPS CQMs as all electronic. Most of at least our bigger submissions for bigger practices are based on electronic data. Some are entirely electronic, but some are supplemented by other data sources. And at Mingle, we've done a lot of all electronic MIPS CQM reporting. In the first few years of MIPS, you may remember there was a bonus for all electronic reporting. We earned that incentive for many of our clients using MIPS CQM reporting in an all electronic fashion. Now, let's compare and contrast. There's similarities, there are differences between eCQMs and MIPS CQMs. Now, the specifications in format are different. The eCQMs are written in technical language and refer to standard code sets, specific standard codes, and collections of those codes called value sets. Now, Medicare CQM specifications are written in standard language. When it refers to codes, it only refers to the two code sets that are reliably standardized in everyday use by all of us. And those two sets are first, current procedural terminology, that is American Medical Association CPT code set, or the International Classification of Disease codes, currently ICD-10 codes that are sourced from the World Health Organization and modified by the U.S. Center for Disease Control for use in the United States. But the two sets of specifications mean pretty much the same thing. In the past, there were some major differences between eCQM specs and MIPS specs, but in recent years, they've been converging and accounting for the difference in language. They really mean it's the same care they're watching for, the same restrictions, the same filtering, the same exclusions. Now, any data that can be used to create an eCQM can be used to create a MIPS CQM. It includes QRDA, that is QRDA1, HL7 messages of any CDA type. CDA is clinical data architecture. QRDA is one version of CDA. There are many others. And a lot of people don't realize, but eCQMs don't require QRDA. If you have someone doing eCQMs for you that's not an EHR, even your EHR, if they're creating an eCQM for you, they don't have to deal with QRDA. It can use direct extracts from the EHR. To be certified, you have to be able to read, you have to be able to write QRDA. It's a standard way to exchange data, but as long as it's electronic, it is usable in for your eCQMs. Now, the reverse is not true. Many data sources that can be used to create a MIPS CQM cannot be used to create an eCQM. eCQM destined data has to be collected by and recovered from certified EHR technology. MIPS CQM destined data can be electronically sourced, but can also be manually abstracted from a paper source or manually extracted from an EHR, and can be derived from a secondary electronic source like an immunization log, a tumor registry, or other specific disease or treatment registries. Each code set exists as a standard and calls for standard usage, but they are redundant and overlapping, and no single standard is agreed upon or required. And the National Library of Medicine lists and tracks 105 standard code sets and offers translational tools for many. It is just as valid, however, to use your own locally grown code set, and most people are creating locally grown code sets. It's called the English language. You're making entries into fields using the text blocks that you choose to put there. Now, if it's free text, it's very hard to query, very hard to measure. If it's structured text, so you're always putting the same entry in under the same circumstances, those are much easier to translate and to translate to the other more standardized languages. Now, there are not as many measures available in eCQMs as in MIPS CQMs. Now, Medicare doesn't create or maintain measures. Medicare sets the standards, judges the various measure candidates submitted by experts and expert organizations, and maintains a library of applicable and acceptable measures. Now, it must be easier to author and maintain MIPS CQM specs than eCQM specs, judging from the current availability and the annual turnover of measures. Much more turnover in MIPS than there is in eCQMs. And that's another reason why we should not be overly quick to eliminate MIPS CQMs for eCQMs. So, without all that under our belt, and now that you're an expert in the differences, let's talk about the process of switching from MIPS CQMs to eCQM. What you should do and what you should not do. Now, I recommend that your analysis and reporting process every year includes a layer of data validation, and that's whether you're using eCQMs or MIPS CQMs. You should take a modest-sized sample of data from the analysis and manually compare to the charts to be sure your performance analysis is accurate. You should take 10 or 20 examples of performance met and be sure that you can find the chart entries that define met performance for that measure. You take 10 to 20 examples of performance not met and look for data that should have made it met. In those cases where your chart audit or data validation shows that the analysis was not accurate, you will launch two additional actions. One, you'll want to look for the error in the data flow. Somewhere your queries are not picking up the data or not passing on to the analysis process. So determine and correct the reason the right data was not reflected in your analysis and get it fixed for future years. Now, you'll also want to correct your report to reflect a higher earned score. You're never going to get quite as good a score from an all electronic process when you supplement it with a data audit step to find errors and correct them. If you want to get your best score, you'll take a complete list of all your performance not met instances, and you'll manually audit the chart for data and correct it when you find performance met data. Now, this pertains to eCQMs and MIPS CQMs equally. The only thing that differs is your options for correcting this year's score. When you discover a correct discrepancy, I suggest you expand your data validation to include all patients who don't meet performance, do an audit, and correct just those. It's an interesting, if you look across all measures, you'll find that missing data is typically always a performance not met situation. And so if you don't pick up the data, you're creating a not met count. When you find data, it's virtually always improving your score. You don't find negative data. You either find data or you don't. And when you find data, you are finding a higher earned score. So in MIPS CQMs, you can take the results of that final audit of performance not met instances, and you can just turn that in as an Excel spreadsheet to us, to correct or update your data. Now, it's usually in an Excel spreadsheet. We can use that to correct your MIPS CQM data. You don't have to correct the data in your EHR. It pays to retrain your providers to record it in the right place that it can be found, or it pays to expand your queries so you find it in these other places. Those things are great work to make it easier year by year and get your scores higher with less work. Now, if you're doing eCQMs, you can correct those as well, but it has to be a corrective entry in the EHR. I'd empower my support staff to take data found in one format and re-enter it in the format in which it can be found by your reporting process, and then rerun and resubmit your new data. That's basically the biggest change in workflow in changing from MIPS CQMs to eCQMs. And it's simply a matter of taking all the efforts you're already making to do MIPS CQMs and just turning off the manual pieces. Do all your corrections electronically, submit new data, run the new analysis. One other error I see commonly made in eCQM projects is to invest too much in infrastructure. It comes down to two expensive recommendations that you don't have to take. One is an Enterprise Master Patient Index, commonly known as an EMPI, and the other is a central data repository. Now, the Enterprise Master Patient Index takes the patient lists from each of your component systems, and it compares more than just the first name, last name, middle name, date of birth. It also looks at phone numbers, addresses, old addresses, basically any data that's in your EHR or practice management system is game to be involved in that. So it can identify patients whose first names are entered differently into systems, who's changed their last names, who changed addresses. It takes all the data, compares it, and gives a numerical score that tells you how likely this is to be the same patient. Central data repositories takes data that exists in all these different systems and translates it into a single common standard language and keeps it in one area so you can draw upon it when you need it. Now, both are great tools with a lot of potential value, particularly if you are actively sharing and using EHR data at the point and time of care every day. But it's serious overkill, that is overspending, if the sole purpose is quality reporting. A good EMPI and a good data repository with solid processes around them can get you to 6 sigma error rates, very low error rates. But the limit of Medicare's comparison between practices on which it bases MIPS scores, on which it bases collection of your shared savings for MSSPs, generally is nearer the 3 sigma level. And it goes out to 2 decimals at most beyond the decile rank. We can get to that level of discernment from data that is typically native to your CEHRT systems without using an EMPI or central data repository. The monumental expense involved in implementing and using that EMPI and central data repository involve purchasing the necessary hardware, licensing the necessary software, and putting a team in place to work the errors every day. And that's key. It takes constant work to take those reports of patients that may or may not match and make a judgment that they do or don't. It takes constant work to make sure that data combines and any errors in the data entry from one system is corrected and brings everything together accurately. So save that expense and effort for when you will use it to increase the value of your care to your patients. You don't need that level of discernment to measure the value of your care for Medicare.